Welcome back to session 6, The Changing Tides of Primary Care. I'm here with Dr. Jane Dunham, who is the Chief of Primary Care of Virginia Mason Medical Center, and Dr. Norris Camo, who's Director of Clinical Quality and Informatics, also in the Department of Primary Care at Virginia Mason. Welcome to both of you.
Thank you, Robin. It is a pleasure and an honor to be here today. And I also just want to thank you for organizing and coordinating this event.
Our pleasure.
Likewise, happy to be here.
Fantastic. So we're going to get on to your presentation, and then we'll take some questions in about 50 minutes.
Sounds great. It is my pleasure today to speak to you along with Dr. Camo about the changing tides of primary care, grace, advocacy, and resiliency during COVID. Our agenda for today, we will cover both an introduction for Virginia Mason Franciscan Health for those who don't know our organization yet. We'll talk about the pre-COVID era and our approach to healthcare, the challenges of the COVID pandemic in 2020, our crisis response and resiliency to that, and then the healthcare landscape today and future directions for that healthcare post-COVID. And then we'll have some time for questions at the end. So first of all, who is Virginia Mason Franciscan Health? We are an integrated healthcare system. We're a not-for-profit organization. We have a fairly large 336-bed hospital. We have 9 regional medical centers and actually 10 as of this week. We have a new one that just opened. We have a robust graduate medical education program that trains residents in both primary care as well as surgical specialties and medical fellowships as well. And we have a very vibrant research institute called the Benaroya Research Institute that does a lot of different research, both for Virginia Mason and in coordination with other programs in the area. We have a foundation that helps raise money for our programs. And we also have a Virginia Mason Institute, which is intended to help train other healthcare programs in our process improvement methodology, which we have really pioneered and has become the framework for which we make change and improve processes within our system. We are part of a bigger healthcare system called Virginia Mason Franciscan Health, which, as you can see, has a large presence across the entire Puget Sound. There are 11 hospitals represented here, and there are also prompt care clinics and urgent care clinics and other services as well. We are very proud to share that we rank #1 in the Washington Health Alliance for delivery on a variety of different quality and performance measures. But we really pride ourselves on this, and I think this is a testament to our focus on quality and the patient experience in their care. So we're very proud to share that with you today.
And this is our strategic plan. You know, we didn't get to #1 or the top 3 in our quality overnight, and it's been a journey of over 20 years using what's called the Virginia Mason production system, which is our way of managing and our way of improving the way we do our work. Our vision is to be the quality leader and transform healthcare, not just for us, but for the whole country and the world. And our mission is to improve the health and well-being of the patients we serve. And you can see what our values are, strategies focusing on people, quality, service, innovation, and various Virginia Mason foundational elements. And if you work here at Virginia Mason Medical Center, you're going to see this pyramid every single day in every presentation, from our CEO to our regional medical centers, to the hospitals, to our administrative centers.
So to carry this theme forward, as you could see in our strategic pyramid, the patient is at the top, and that is really a big part of how we approach our care and how we improve the patient's experience of their care. I think one thing that's very special about the way that we involve our patients is they actually participate in our process improvement events that we have, and are members of the team that are making changes in the workflow. So I think that's a very, very special part of how we involve our patients. We want to make sure that patients have safe, high quality care, that they're getting care when they need it at a cost that is affordable to them, and making sure they're having a remarkable experience along the way. And in addition to that, it is also a very large focus of our organization that our team members also share in an excellent experience in their workplace. We really promote a strong culture of inclusion and respect for people. And our belief is that when the team members are having a positive experience in their work environment, that translates to a positive experience for the patient. So this is always at the forefront as well.
All right, so I'm going to go over what healthcare looked like in the pre-COVID era, and not just pre-COVID, but going back to the late 90s. And I'm going to share with you Ted's story. And Ted's story is going to be very familiar to everyone who works at Virginia Mason, because this is part of our introduction to the Virginia Mason production system. Everyone goes through the session and learns about Ted's story if you work here. So here's our patient, Ted Gakowski. He's a retired engineer and has had lymphoma since 1999, and comes to our medical center for weekly 6-hour chemo treatments. And his image and story are used with his family's permission. Ted actually passed away in 2014, but the spirit, his spirit lives on in sharing his story and inspiring us to improve the work we do every day. So here's Ted's journey. So if you're not from Washington State, you'll see here in the Google map on the right that we have lots of bodies of water that we have to cross. And Ted lived in Sequim out on the Olympic Peninsula. And look at his commute. So 2 hours, 9 minutes to get around the Puget Sound just to get to Virginia Mason Medical Center and to get his 6-hour chemotherapy treatment. Then he would have to drive back once a week, and his day would start at 5 a.m. and end late at night. And so in the late 90s, we didn't have VMPS. We did not have a way of incorporating patients as partners, of continuously improving. And so as Ted came to our medical center for treatment, he also became part of our partnership with patients to improve how we care for patients. And so you can see this house that represents what the foundation of our strategic plan is, the Virginia Mason production system. And if you look over to the left column, you can see that respect for people is one of the pillars of the Virginia Mason production system. Patients as partners, engaging individuals and teams, and on the right side, all about continuous improvement, being the quality leader, reducing waste, improving appropriateness, outcome service, and accelerating our impact through plan, do, study cycles. And at the heart, in the center, is all about people taking care of people. That is the core of what we do. So around 2001, this was Ted's journey after he checked in, right? He would park, go to the front desk, and then go to the lab, up to oncology, down to the infusion center, go across to radiology, go back to the lab, go to radiation oncology, go to the surgeon office in a different building, and then go back to the parking lot to his car. So there's a lot of waste in the spaghetti diagram. And I won't go through all the improvements that we made, but if you go to the next slide, this is what we were able to accomplish with the Virginia Mason production system in reducing his journey within the medical center. Not that we reduced all waste and all walking time, but it dramatically improved his experience at our medical center.
So I wanted to take a moment to discuss what some of the challenges of the COVID pandemic have been and their impact to how we're delivering care to patients now. And just as an overview, and I think people are probably fairly familiar with this, but I'll just point out a few milestones or key moments in the COVID pandemic that have affected us in the healthcare industry. We had our first case of COVID in January of 2020 in the United States. And then soon thereafter, by March, we began experiencing shutdowns and social distancing measures. And a lot of forthcoming guidance around infection prevention and resource consolidation because of limitations in things like protective equipment for managing patients who are ill. Medicare Telehealth was approved in this same time frame. And also concurrent with this, we saw a lot of workforce displacement and departures, which I'll discuss a little more in a moment. So with all of this, there was a lot of disruption to regular care. There were patients who were deferring their care because they were fearful of coming in, and there were problems with patients accessing their care, so that a lot of elective and preventive services simply were stalled or not completed. So in response to that, we had a large outreach effort to help to bring patients into care who had not been in care or were out of care. And then as we continue into late 2020, I think everyone knows that we had the first availability of a COVID vaccine, and first responders were vaccinated in early January of 2021, and then the vaccination of the general public began, and now we're seeing vaccine mandates for healthcare workplaces now. One of the major challenges that we had was infection prevention measures. As you can see from the picture here, the time that it takes to employ infection prevention measures with each patient was definitely amplified by COVID. It takes time to don and doff these things. It's uncomfortable. It impairs communication, and it takes longer to have conversations because people cannot see the lower half of the face. There were a lot of supply chain limitations. There were, at the beginning, a lot of constraints in terms of mask availability, and we were really protective of our personal protective equipment. There was screening at entry employed, heightened sanitation measures so that we were doing this aggressive sanitation between every patient that we see. And we also had to separate the flows of patient visits. And I think this may be something that wasn't always very visible to patients coming in, but we had to devise an entirely separate entrance and flow for patients who might screen positive for symptoms, which had to be staffed with a separate workforce in order to take care of those patients and keep the patients who were ill separated from the patients who were well and avoid the spread of infection. So this really complicated things. And it was changing regularly, oftentimes day to day, and at least week to week. So we were constantly having to adjust and respond. And you can imagine that this would be not only time consuming, but tiring and mentally taxing for the healthcare workers. We also had a huge surge in phone and message volumes since the pandemic began, with many messages related to questions about symptoms, the status of vaccine availability, questions about boosters and eligibility for boosters, more recently, monoclonal antibody therapy and who can receive it, work restrictions and FMLA requests from patients, requests for exemptions from having the vaccine, questions about visitation, both in the clinic and in the inpatient setting, and a lot of questions in response to media information that would come forward from week to week. So, anything from what is COVID toe and do I have that, to long COVID questions or questions about novel drug therapies that might have been publicized in the lay press, such as hydroxychloroquine. So much more non-face-to-face message volume and phone volume than we were accustomed to. And then in addition to that, not unlike other areas of the workforce in the United States, healthcare has seen a tremendous staffing crisis in the last year. And you can see just general unemployment rates from August 2019 to August 2021, where there was a huge uptick in unemployment right around March of 2020. And in a healthcare environment, this was impacted by several different factors. We had temporary shutdowns where there was just no work available. We had to place our providers on furloughs in some cases because we did not have work for them. There were salary cuts that made it difficult for some people to choose to continue their employment. There were family care needs that required people be at home. There was also this looming fear of infection and people having more hesitancy about coming to work because of that, and heightened job stress, of course, because of all these things. And then competing opportunities outside of healthcare, where what we're finding now is that even places like restaurants are offering unusually high salaries right now, or hourly rates, to compete for this very limited pool of potential employees. So all of these things have created more challenges for us. And another impact to this is, and I think this may not be as transparent to those who are not in the healthcare workforce, is that this has really forced us to limit the services and the hours that we can offer, because if we can't staff it, if we don't have anyone that can be there to check in the patient, set them up for the test, collect their blood, make sure that the office is open and exam rooms are kept in good supply, we can't provide the service. So that has limited what we can offer to patients. And so what had been more expanded hours in the past have become more contracted. So the sum total effect on the patient experience is pretty extensive. From the point that you call to make an appointment, oftentimes there are much longer waits on phone queues than you would have had in the past. It takes longer to get in for an appointment. And as I mentioned, there are more limited hours of operation. There are fewer in-person appointments. And part of that is because we do have to limit the number of people in one space at any given period of time. And so we have had to switch to other avenues for delivering care outside of the traditional face-to-face visit. We've had access point restrictions, communication challenges. Patients find that the staff tend to be more stressed. There are more infection precaution requirements that they have to comply with. There has been a disruption to recall processes, and where patients might have been used to receiving a mammogram reminder letter, for example, every year, they may not have received one in the last few years because there were not resources available to provide that. And that may have been true for preventive services as well. Patients have lost health insurance. Patients also have a fear of having exposure to COVID and have been reluctant to come in for care. And therefore, there has been care that has been deferred, and this has exacerbated already present disparities in healthcare. And then there has just been a general isolation for patients, leading to decline in the management of their chronic health conditions. As far as reasons that patients, when surveyed, cite their reasons for not getting in for healthcare, it ranges from being afraid of getting infected to feeling like they were discouraged from coming in, or feeling like they needed to step out of the way because somebody else had a higher need that they needed to give their spot to someone else, or simply that their healthcare provider wasn't available, or maybe their symptoms weren't bad enough to warrant coming in for a visit.
And here's the data, right, showing what kind of healthcare was impacted by the pandemic. And the preventive care that we provide in primary care, people deferred that. They didn't even come in, secondary only to dental care. And you can see all the ripple effects of the pandemic to all different types of care, not just primary care, but specialty care as well. So this is a cartoon from the New Yorker, right? And this is from 2018, pre-COVID. And here's this wrathful God creating lightning bolts to increase our mortality rate down here on Earth. And here's his colleague saying, I hate to be a downer, but statistically, people are more likely to die from heart disease than by getting hit by one of those things. And click the next, and that lightning bolt that hit us in 2020 was COVID-19. And here's the data that shows mortality in 2020. If you look at the column on the very right, these are the causes of death, the leading causes of death in the United States. Total deaths of 3.35 million, but still the number 1 and number 2 leading causes of death were still heart disease and cancer, and then behind that was COVID-19. So this is the challenge that we were facing as folks were delaying their care, not coming in for care, plus all the different challenges that we were experiencing that Jane outlined earlier. And you can see that cancer screening rates dipped in March, April, as folks stopped coming in for breast cancer screening and colon cancer screening and prostate cancer screening. And as healthcare organizations, including ours, adjusted, right, we got our rates back up, not quite to 2018, 2019 levels. And then, oh, by the way, in May 2021, for colon cancer screening, the USPSTF guidelines were revised to include individuals aged 45 to 49, in addition to individuals 50 to 75. So we had a larger denominator of patients that needed screening. Go ahead. And here's prostate cancer screening rates. So, well, what's the missed opportunity to detect cancer from this dip? And they estimate around 9 to 10 million individuals may not have been screened because of the delayed care pandemic. And then this is newly identified cancer. So we talked about screening, but you can take a look compared to a baseline week pre-pandemic. You look at the weeks in March through mid-April, and you can see that the newly identified common cancer in patients per week had declined during those early days of the pandemic. And this was around 40-something% decrease in the newly identified cancers in the US, which corresponds with what they found internationally in the Netherlands and elsewhere.
So our response to this has been several-fold. In particular, we really decided to focus on outreach to the patient. We had done some targeted outreach prior to COVID, but with the drop in volume of patient care that we saw post-pandemic, this really prompted us to take this outreach to a new level. We expanded our outreach efforts to a broader population for more specific targets, and we increased both our automated outreach as well as our manual outreach. So you can see that for annual wellness visits, for example, we have some automated outreach that happens first. And ultimately, if we still cannot connect with the patient, we call them. And we also have very active outreach going on for colorectal cancer screening and pediatrics wellness visits. And then locally and much more manually, outreach for specific disease processes like diabetes and hypertension and elderly patients as well. So our wellness outreach efforts, just to show you an example of how this has changed, over the last year, there has been a tremendous uptick in the amount of outreach that we have done for both adult patients and pediatrics patients for their wellness care. And it has just steadily ramped up over the last year. And for colorectal cancer screening, the same is true. And I think this is really important because, as Norris was alluding to, we have an expansion of the colorectal cancer screening guidelines. And in fact, we are seeing an increase in the incidence of colorectal cancer in younger patients. And this may not be entirely visible to our patient population. Many of them may assume because they are young, they are not necessarily at high risk for this and may put this off thinking that they can wait. But in fact, if their risk is going up, they should be getting screened sooner. And so we have really been putting a focused effort around this to make sure we're getting people in. For patients who are out of care, this was also a very new effort for us to bring them in. So immediately post-pandemic, we began outreaching to patients who we had not seen in a long period of time to make sure that we were caring for them, and have been steadily increasing those numbers as well.
And part of our efforts, even pre-pandemic and accelerated during our pandemic, was to work with our data analytics team to create registries and dashboards that were able to track disease conditions like diabetes, hypertension. But one thing that came out of this work was a depression behavioral health registry, initially created for our psychiatry team and our behavioral health team, but expanded to include primary care. And so you could see that these are PHQ-9 screenings that are done. These are this is a standard questionnaire to screen for depression and identify remission of the disease. And you can see in the bottom left quadrant there, you can see that the total scores of 10 and over, so the higher the score on a PHQ-9, the worse the depression severity. You can see that that went up between March 2020 through this year. And what you've been hearing about in the media about increased anxiety, depression, mood disorders during the pandemic, it's real. And this is our actual local data. And so what we've been able to do is to extend our outreach and tracking standard processes to make sure that folks with mood disorders were able to be seen. And, you know, a part of what we've done was not only pivot to doing virtual care, which we'll talk about, but be able to connect with our patients on a more frequent basis during the pandemic because of some of the new tools and processes that we implemented. And this is our hypertension control. So if you take a look at what is controlled hypertension, what counts is blood pressure measured in person in the clinic. And that's how CMS or Medicare decides whether or not blood pressure that is reported is valid or not. And you can see that we were doing pretty well in terms of our hypertension control. And then it dropped both because patients weren't coming in to get their blood pressure checked, but we've made a concerted effort to get folks back in for their preventive care and also for their chronic condition care. And we're back up at target level as of June of this year. So never waste, a good crisis is what some folks say, right? And what happened in March of 2020 was that CMS started allowing Medicare beneficiaries to receive telehealth services at any location, including their home, as part of a presidential emergency declaration under the Stafford Act and National Emergencies Act. And you could see the dramatic increase in the number of Medicare fee-for-service patients um, doing video or telehealth visits after March 17th. Prior to that, because of limitations in the regulations of what Medicare would reimburse in terms of telehealth type visits, or geographic restrictions, it was quite cumbersome for us to, and other healthcare organizations for that matter, to really implement telehealth and still meet the requirements of the prior regulations. So this was a big change for both us in the clinical world and for our patients, right? I remember for myself, due to concerns that we would be running out of gloves and masks and other PPE, we had to shut down our clinic, and I had to move to another location and switch all of my patient care to virtual care, video care, right? And that was a really big change. And I stopped seeing patients for the most part in person for about a month and a half. And in the beginning, we ran into a lot of difficulties, both adaptive change, getting providers to accept this mode of delivering care, figuring out what was good for video or telehealth-based care versus not good. How could we safely do this and effectively do this? Running into challenges with audiovisual technology and sending links out. I remember that there was a lot of frustration in the beginning about needing a certain type of browser to be able to access it. A lot of challenges being able to see each other, hear each other. And a lot of that's been worked out now, but in the beginning it was really, really tough.
This graph shows the distribution of telemedicine in different areas of the country. And as you can see, there's quite a lot of regional variation with this, the darkest blue being areas where there has been the most telemedicine occurring, and the lightest areas being where there has been the least. So we definitely have concentrated areas in the Northeast and the West Coast, and the Midwest, the middle of our country, tends to be relatively scant in terms of video visits occurring. You can imagine that there might be different factors for that, but potentially this is an area where the healthcare organizations may have less technology available, or patients may have less home technology in order to connect with a clinic. And these are other demographic characteristics that have been associated with telemedicine. So things to the left of the middle line are factors that would indicate lesser likelihood of seeking care via televideo, and those to the right, higher likelihood. Standouts for those factors that would make a patient less likely to seek telemedicine are age greater than 75. But surprisingly, the Asian population has a fairly low uptick in televideo, which you might think would go the other way. Non-English speaking patients tend not to use this service as much. Interestingly, Black patients tend to access care this way more often than other patients on average. And I think one thing that is also interesting is that median income does not really appear to play a significant role in whether or not patients are accessing care via telemedicine. And this may be because cell phone use is such an easy way to do this. And cell phones are really ubiquitous. Everybody has a cell phone now. And so it makes it possible for nearly everyone, regardless of their income, to have a visit this way. We do see that patients who have higher level of complicated disease or comorbidity access care this way more frequently, and that may have to do with the fact that it is harder for those people to come into the visit in person. And I think there's a lot of assumptions about video care that may not be entirely correct. Some specific ones that I would mention are that patients are often of the impression that they must have a personal computer in order to conduct these visits, that older patients are not able to do these visits successfully, that it's just too difficult. Patients who don't speak English do not realize that they can have an interpreter. They assume they can't have an interpreter, so they don't opt for this service. Family members are worried that it won't be easy for them to participate in the conversation. And some people feel that the video visits would be impersonal. And others make the assumption that preventative care cannot be done virtually. And on the flip side, there are other people who assume that all care can be done virtually, and that's also not necessarily true.
And despite the rocky rollout in the beginning, we're quite proud to have rolled out telehealth and televideo successfully for our patients. And this is an article in Becker's Hospital Review outlining the 25 hospitals completing the most telehealth visits during the pandemic, and the charges as well. And so we're proud to be right up there with some of the heavy hitters in American healthcare, some of the big university hospital systems. And I encourage you to take a look at our website, virginiamason.org/telehealth for patients, and watch this video of Dr. Jillian Worth, who's one of our family medicine physicians, describing a televideo interaction she had with her patient Katie, who is a professional musician and cellist who started having tingling in her fingers, and the ability for the doctor to see her patient in her home environment in a way that she wouldn't have been able to in clinic.
Should I play a little bit of this, Norris?
Yeah, go ahead.
This portion of New Day Northwest is sponsored by Virginia Mason.
The pandemic has changed a lot, including how we go to the doctor. Virginia Mason has expanded their ability to see patients through their patient portal and also an app called Virtual Mason. I talked with a doctor and also with a patient whose televisit actually helped her get the right diagnosis.
Katie, you had a video visit a few weeks ago, and I'm curious what led to the need for this appointment.
Yeah, so I am a full-time musician and creative person here in Seattle, and so my hands are kind of my life, and I noticed that I was having some numbness in my left hand. And after, doing some like home treatment of just trying to rest or whatever, I noticed it wasn't really getting better and I was getting concerned. So I just messaged my doctor since like forever, Jillian, on the Virginia Mason portal, and I was like, hey, do you have time? I don't really want to make it over to Bainbridge to see you, but is there any way that I can like just talk to you or something? And yeah, her team suggested doing a bit of like a video chat.
And that's what you did. Dr. Worth, through the video visit, sometimes we're a little worried, well, what if we don't get examined? What will happen? But through the video visit, you were actually able to make a diagnosis maybe more easily than if it hadn't been a video.
That's right. And so what's wild about video visits is that we all didn't know what will it be like to talk to people through a computer screen. Some of us have done the Zoom meeting and talked to our families, but doing doctoring through the portal has been challenging because it's like an email game of tag. But doing a video visit is actually it offers all sorts of opportunities, because not only can we see our patients and see their faces and see them again after this COVID pandemic timing, where we couldn't see anyone in person, but we can also do some exams that we never thought we could. So some of that has, for Katie, it was that I could watch her show me with her hand what was actually happening. And then she had her cello, so she's able to get her cello and show me with her actual cello how she was holding and gripping the cello. And therefore I was able to notice that she was compressing part of her hand that can lead to carpal tunnel syndrome and make that tingling sensation. Now that would not have happened in my office because she doesn't bring her cello to the office usually.
No, I would guess she doesn't bring her cello.
No,
so that was pretty cool. Katie, do you have your cello there? Can you kind of show us what you showed the doctor?
I do have my cello here. One second. So I was able to kind of show her the positioning that I usually have with my hand. It's either like this or like this. In any which way, it really compresses the wrist, is what she noticed. And, you know, I just kind of was able to play a little bit and she could see the full range of movement.
Dr. Worth, you got a concert and a televisit.
I did.
All done at the same time. So, Katie, was it hard to make this appointment or did you get in pretty quickly? What was your experience?
It was incredibly fast. I think I messaged her team at like 8:30 in the morning, and by 9:30 I had an appointment with Jillian to just, you know, kind of see what was up. So it was incredibly fast, incredibly easy, and also really intuitive on how to actually, you know, get online and get to the portal so I could talk with her.
Which is great. Doctor, I'm curious, when you, I don't want to make it sound like you're being nosy, but when you see patients and you can see their homes and offices and maybe the stuff around them, does that actually help you in some way?
It does. It harkens back to a time when we did more home visits. When I started my practice here about 20 years ago, I usually saw a few people at home a year, usually very chronically ill people who just couldn't even make it out of their home. What this is offering is actually seeing people in their home setting, which has been quite incredible. Teenagers especially, and some of my elderly patients, to see how they're living, instead of wondering or sending out a physical therapist to assess their bedroom or their chair, their caregiver can show me their bedroom. You know, the teenager who I can never get a sense in the exam on what life is like at home with their parent, I can see that interaction on the video. I can watch mom storm off. I can engage in that conversation and do some parent coaching in their actual house. It's been incredible. Most of my partners have said it's a window into people's lives that we never even knew we could have.
Katie, for you, what was the virtual experience like? I think, you know, a phone call would have been very different than being able to see Dr. Worth.
Yeah, I felt like I actually had a real like personal connection over video that for me I don't think is really as possible when talking on the phone. And there was a bit of like comfort just like seeing her face also, and like I've seen her before, and it just made the whole meeting a lot easier to kind of just immediately show and open up and have that other layer of communication, that visual layer of communication.
I hadn't really thought about that, but you get to see your doctor, but you don't have to leave home, so you've got that comfort. You don't feel that, you know, little bit of anxiety that always comes with going to the doctor's office.
Yeah, I'm not waiting in a waiting room for who knows how long, or
not hanging out.
Exactly.
Dr. Worth, the virtual care is going to continue even after the stay-at-home orders are lifted gradually. It seems like that's another layer of care, as you mentioned, that'll be available to us. What else is coming down the road for you?
Well, what's wild is this is something that we as an organization at Virginia Mason have wanted to roll out for our patients, this virtual care. And Virtual Mason is the website that we can use to get people into this secure HIPAA secured portal to do video visits. We envisioned it as something we would do with patients for things like depression or anxiety, things that don't necessarily require an in-person exam, because there's lots of conditions that we can manage without making people miss a day of work or have to get childcare for their family or have to even leave their home. But then there'll be a time when we start to envision, as we're bringing patients back into our facility, that this can be part of my working day. Let's say I could do half a day on Monday where I'll work from my home and give virtual care to my patients in their home or their business or wherever they happen to be. And we are all just loving it because we missed our patients. We miss seeing their faces. It's very strange to give care over a phone. You can't read the room. You can't read the emotion. You can't really understand how someone's feeling when you can't see their face. And eventually we see that biometrics will be collected at home too. So people will get probably down the road one day a kit that'll have a blood pressure cuff, a pulse oximeter, a pulse measurer, maybe even a special scale in order to get their diabetes care at home or to get their heart disease care at home. And then we won't have to have that person have 2 caregivers take the day off of work to bring them into our clinic to wait in line to sit in the lobby. Instead, they'll be in their home. One thing that's happening that as this pandemic goes on is that we are starting to bring patients back into our offices, and we want to make sure people understand we're doing that in a very safe way. I would say it's coming back to my office and to my Virginia Mason offices as far, across our organization is safer than going to the grocery store right now, because we are masking every patient on entry. We're checking their temperature. We're making sure they don't have any of the symptoms of COVID-19. And therefore, we can give care in person. But this is just a great option for those people who either don't want to come in or can't come in for some other reason.
That's good to know. Okay, Katie, play us out.
You got it.
I think that there's a lot that we have learned over the last year in how we can best offer this to our patients and the advantages of it as well. It really is very convenient. People do not have to travel for the service, and they can remain at work or stay with their children at home if they need to be at home. And we can even connect with patients while they're in care facilities, which was very difficult to do in the past. It is easier to access these visits. There is generally a shorter lead time to get in for these appointments. And cell phones work very well. There is no reason why you need a personal computer in order to request this type of visit. Just having a cell phone typically works. The platforms are really straightforward. They're built to be that way, so they are easy for patients to operate. And one advantage, in fact, is that multiple people can participate, and we can even have family members who reside in other states participate and have a face-to-face video connection instead of just calling somebody on the phone. And interpreters can participate too. We can bring on a virtual interpreter to the visit and make it an excellent experience for the patient. The other thing that has really been a neat aspect to this is we have a window into the patient's world via these video visits that we never had before, and we're able to see the patient's home environment. And sometimes there's that thing that they meant to bring to the visit that they forgot and they left at home. But when we are seeing them in their home, they can quickly go and grab it, or they can check their blood pressure for us in the moment, or check their blood sugar, or various things like that, where it's just right at their fingertips. And that's just so great. Oftentimes we can do preventive visits virtually as well, unless there's an aspect of the preventive visit that necessitates an exam. For example, a woman needs her gynecologic exam. Most preventive care is really more about a whole range of different screening and preventive services that require planning and discussion and ordering tests or vaccines or other procedures, but don't necessarily require that we are face-to-face in order to facilitate that. Patients can use home monitoring tools while they're there during their visits. And another great thing is there are no masks needed. So for people who find it difficult to hear, that rely on seeing people's lips move in order to communicate effectively, it is easier for them to communicate when they're on a video call, and they can turn the volume up as loudly as they need to. And there are some things that are still not going to be video appropriate. So, sometimes there are medical concerns that do require an examination. If somebody is having ear pain, or if somebody is having acute abdominal pain, typically we are going to need to lay our hands on that patient in order to see them. So it's not appropriate for everything. Likewise, for well child visits, it is oftentimes easier to conduct those visits in person because kids are growing. They need accurate height and weight measurements all along the way, and the virtual platform can be difficult in those cases. And sometimes patients just really need that in-person connection. They need, their physician to, lay hands on them. They need that healing touch. And I think also we need to caution people to be wary of the promise of virtual only health delivery products, which they are coming to us now. We are seeing those being offered, and they do offer some advantages, but they cannot replace the entirety of clinical care.
All right, so where does that leave us today? And I want to get back to Ted's story. So would telehealth have been the missing link, right? Initially in 2001, we eliminated his journey within the hospital. But what if we were able to eliminate travel to the hospital and cut his commute time down from 4 hours plus to 0, right? And so, I'm wondering if he were still with us today, would he be conversing with his oncologist and surgeon and connecting with them through a virtual platform? And what does tomorrow hold for us, right? He might have had to pause chemotherapy visits as we had to adjust to COVID care in our hospital. Could he have received chemotherapy at home or at a local institution or an office instead?
So as we wrap up, we wanted to offer some tips for patients and their advocates for how to successfully access care during these challenging times. We'd encourage everyone to keep an open mind regarding virtual care and seek care where virtual and portal communication is supported. Try to arrive early for visits. Anticipate that there will be more time spent up front at check-in with screening and remasking. It is becoming more common now for medical organizations to replace masks when patients come in the door because they are fresh and clean and they're medical grade. Make a list of concerns. Lists and agendas help to maximize what you're going to get out of your visit. And when it's already difficult to get in for care, getting the most out of each and every visit is very important. Send information ahead as much as you can. This could be done oftentimes through portal communication to set up your visit for success. Sometimes practices will send questionnaires in advance that are optional for patients to fill out, and we would encourage people to complete those ahead of the visit. And keep messages via the portal short and succinct. Generally speaking, you will receive a faster response from your healthcare provider if the question is direct and simple. When they become more lengthy, it takes more time for the provider to return with an answer.
And when you're doing a video visit or not familiar doing telehealth, ask for help. When you're in the office or by the phone. Our staff is here to help. They've seen all the different ways in which telehealth setup can go wrong, so they're here to help. Next point is to be your own screening advocate and make sure that you schedule an annual wellness visit. Don't wait for reminder letters. All that screening that needs to be done at all times of your life, that is still important even during a pandemic. Next point is to respond to outreach communication. So we're going to be sending letters and messages and emails about accessing care. And so we won't be sending that out if we didn't have the capacity to see you, or if we thought it wasn't safe for you to come in. So we're sending these out because we want you to come in. Next point of advice is at your visit, request refills for prescriptions expiring within 3 months. So for stable chronic medical conditions, we'd like to refill your medications for the whole year. So that cuts down on requests and messages that come into us, and this reduces delays. Next point is to ask for a visit summary. So we have the capability to write patient instructions, include your medication list, your problem list, and specific education materials. And everyone who has an electronic medical record at their clinic should be able to give you a summary of the visit. And then lastly, please, please, please be patient with our staff and frequently changing processes. So you heard about the staffing shortage and the transitions that we've been experiencing in healthcare. And things can change week to week, day by day, based on new information that's coming in. So please be patient with us, and then we'll be patient with you.
That is the conclusion of our presentation, and we would be happy to entertain any questions that people may have. It is.
Thank you so much. That was really comprehensive, and we do have a bunch of questions in the chat. I think one of the biggest questions is about going forward as emergency regulations expire on telehealth access. Will providers be able to choose whether or not they continue to offer telehealth? How will that work?
Yeah, so with our contracts, we expect to continue to be able to offer video care as we have been now. It has become, really the new norm now, and we imagine this will continue to be a regular part of our practice that we unfold. Probably could represent as much as 25% of our regular care as it's panning out now.
One of the things that we heard in Io Dolka's talk about how advocates can help with the triaging of telehealth is just basically doing that interface. And you mentioned it also in your talk in terms of, there's a lot of pressure on the providers, and so advocates can help in explaining things to patients. What about when patients are unable to explain what they need? Like there's a question in the chat about elderly clients that can't get to the phone fast enough when they're trying to get stuff scheduled. How do you recommend patients deal with those issues? And also, do you see any future where there will be home visits of doctors in primary care?
Norris, do you want to comment first? And I'm happy to comment as well.
Yeah,
I'm sure we
sure.
both have thoughts.
I know I gave you a lot in one question.
Yeah, no, there's a lot of barriers, for a lot of our patient populations, and so I think being able to understand what those are and to be able to document or have someone who knows you in your particular situations, what your relationships are with your family members who may be your advocates, or a third party advocate, that's important for us to know. And I think one of the benefits of primary care is that you have a relationship with your PCP, right? That's the advantage over a standalone telemedicine company or going to urgent care where you kind of have to start all over again every time. So develop that longitudinal relationship so we know not just your health conditions, but you as a person.
Yeah. I'm thinking about the part of the question that was relating to how do you help patients that can't get to the phone on time, or, things like that when they're, receiving calls and they don't know when they're going to get them. And also, it's also difficult because, patients are receiving calls from a lot of different places, and sometimes you can't tell who it is. And, there's so much advertising calls that we receive now, and people sometimes are hesitant to answer the phone. So, I do think that it might be a time when you could leverage portal communication and make planned calls instead of waiting for a unpredictable call, but to respond and say, I know that I need to schedule this particular test or this particular appointment, and I am available at this certain time, and could someone reach out to me then, so that it's in a more coordinated fashion instead of unpredictable. So that was one thought. And as far as the part about home visits and how that might take shape in the future, I think it's a complicated question, because right now we are dealing with relative shortage in our healthcare workforce, and obviously it does take more time to make home visits because you're traveling from place to place, and so that can be difficult. But I do think that there's a couple of thoughts that I have. Certainly there are often home health resources that can be leveraged by way of a home health nurse that can come out and be the eyes for us and obtain information, vital signs, et cetera. And I do think there's going to be an opportunity for more technology at home to help us gather information. It's not extremely accessible yet, but I think it will be coming. So that will help us, remain better connected, even if we can't, physically get there ourselves. I think we can put more data, at the point of the in-home care.
Yeah, and we did talk about that in artificial intelligence being one of the big mega trends affecting healthcare that all advocates should be aware of. And that is actually all the time that we're going to have with you. Unfortunately, there's so much more to talk about, but I just want to thank you, Dr. Dunham and Dr. Camo, and thank you for all the good work that you're doing. And we're very appreciative of you sharing your time and your wisdom today.
Thank you so much, Robin.
Thanks so much.
Okay, bye-bye. We'll be back in 15 minutes with Dr. Danny Sands.